So firstly, can I say thanks very much for inviting me. I think that you all are innovators and you've been way ahead of the rest of the country for quite a long time. And two of my favourite people are there that I've seen on screen, i.e. you, Joanne, and Mary. So you're both a tough act to follow. So I thought that I would try and go through some imperatives that I think are important for us in the next financial year. By the way, it says from a tech standpoint, I can hear my own voice as an echo. Is there any way you can? That's better. Perfect. Great. Thank you. All right. So look, I thought that I would go through what I think are some imperatives for the coming year. But before that, I thought it's worth reflecting on what has happened over the last 4 years. So remember, we started from a blank sheet of paper coming out of the COVID pandemic. So back in 2019, the NHS long-term plan was agreed and funded. And for the first time ever, we had NHS delivered smoking interventions across all inpatients and maternity settings. And this is the first time ever that happened. So it's groundbreaking in and of itself. And the second key point to that was that it was going to be opt-out. So we were going to move away from the model that didn't work, i.e. waiting for people to come and ask us if they'd like treatment. And we were going to systematically identify and treat people who smoked on an opt-out basis in the same way as we do when people are admitted with diabetes or pneumonia or pulmonary embolus. We treat them, we identify the problem and we treat. And so these two things, that it was systematic and it was opt-out. And the third thing was that it was funded and there was an expectation and an assurance process wrapped around it. And this program started back in, probably people got going with it in 2021, and here we are now in 2025. So we're coming toward the end of year 4, and we shouldn't forget the progress we've made. So pretty much 95% of all mental health trusts, acute inpatient trusts and maternity pathways now have this opt-out model in place. And as a result of that, in the last 12 months or so, we've identified about 250,000 people who smoke going into these 3 settings. And we have now started treatment for tobacco addiction across literally many thousands, scores and scores of thousands of people have now received treatment that prior to this program, they would never have had treatment. So it's pretty amazing. We've had thousands of people who've successfully quit smoking and many more who've been smoke-free for a substantial amount of time, giving them the hope that they will eventually become smoke-free. So let's not forget that. And I have to say the North East and North Cumbria have been at the cutting edge of all of that. All of the national graphs and assurance things show me that North East, North Cumbria are doing an amazing job. And actually the rest of us can learn quite a lot. So that's the first thing to say, and that's brilliant. But what we can't do is rest on our laurels because we know that some of these hard-fought battles to implement these services are at risk. And I just actually wanted to share one slide, and I think these are my kind of thoughts for the next year in terms of what I think we probably all need to focus on. Can you see that okay? I can't actually hear anybody now, but I'm assuming you can see that. So I think these are the imperatives for the coming year, and I'm sure you all know this. So the first is sustaining our services. Now, I'm not sure about, I think you guys have got 3 ICBs for this year in 20. So when I say this year, I mean for 25-26, the funding is going to go into ICB baselines for the tobacco dependency services, and it will the money will go in with everything else. It'll go in with hip replacements, with A&E, with cancer care. It's one gigantic pot of money that ICBs receive. which is great because for the first time, then this is not funding that is decided on a yearly basis. It means the funding is hardwired. It's there forever. There will always be an allocation. So that's good news, and it means that some of the short-term contracts that people have been given, or TDAs have been given, hopefully will become permanent contracts, which has been a big issue across the country. However, the threat is that ICBs who have the freedom to decide how they spend their funding will potentially put some of the tobacco services at risk, and that's for us to do as much as we can with national leverage, but locally to make sure that our ICBs and their prevention leads fully understand the impact of these services. So funding is really important, and I think we all have got to work on the key decision makers to make sure that they understand that these services address health inequalities. They impact our hidden populations, the most deprived in our communities. The second thing is the uptake of effective treatments. And I know Joanna has done a shed load of work on this locally together with local authorities. So, for the first time ever in a long time, we have a full armamentarium of treatment options, of really effective treatment options for our patients. We have, of course, NRT, and they should be on the list. But actually, the three most effective treatments that we have for smoking are varenicline, cytosine, and e-cigarettes, and especially in a mental health population, which I think is the focus of today. E-cigarettes are particularly effective. However, for the first time in a long time, we've had varenicline back. It was off the market in 2021. It came back toward the end of last year. And I think it's really important that collectively we get as many people using tablet pharmacotherapy as well as e-cigarettes, as well as NRT. And I know that I was at a forum in the Midlands and I asked the question of colleagues from local government, and there wasn't a single area that was using cytosine, and only one of 11 ICBs that had started to use varenicline in the community. So, and it's been available now for the last 5 months. So I think that we have a responsibility to make sure that cytosine and varenicline uptake is there because they're really effective, and it means that more and more people will become smoke-free and quit permanently. And again, that's within our local control to do. The third thing, there's no particular priority to any of these things, by the way, they're all priorities. It's the efficiency of our pathways. So we know from the national data set that there are record numbers of people being identified as people who smoke when they're admitted, which is great. And we know that depending on the setting, acute mental health or maternity, many of those patients are then referred to our in-house tobacco dependency service. However, there could be more. I think we're about 70% in the acute sector. We're around a similar number with mental health and maternity, but we could be higher in terms of the number of people referred to our in-house services. And then the number of people taking up treatment within the in-house services could be increased, and transfers of care. So at the moment, about 40% of people who are admitted and then discharged from these services are transferred on to ongoing treatment in our local government services. So, what more can we do to increase that? And then finally, data. And I think I heard Mary talk about data. Data is critical. It's critical for lots of reasons. Firstly, we want to be able to shout about the impact of these services. And the only way to do that is through data collection. Across the country, around 70% of acute hospital trusts are submitting data. Around 50% of mental health trusts are submitting data. And also we look at data quality, i.e. the type of data that's being submitted. And there's work to do still on areas improving their data quality, which can include things like quit ascertainment. So I think this next year, improving our data quality and data reporting is going to be really important, because with the data, we can then make our return on investment arguments with our ICBs to make sure that they sustain these services, and we can show the impact that we're making on the communities that we serve, especially with health inequalities. So I think these are the four big areas for this coming year that are largely within our own gift. So, my local patch, which is Leicester, there are lots of things here that we own and that we can do that's within our sphere of influence. And both national, regional and local things can be done to support these four areas. And yeah, so I think these are the most important ones. Now, what would be really nice is if, the next year or the year after, there was additional funding and we could branch out into other areas, like, for example, ED or outpatients. And I'm hoping that will happen, but I don't know that. So in the meantime, I think we really need to double down on really focusing on these four areas. So I think that's actually all I was going to say from a slide standpoint, and I'll stop sharing and happy to take any questions.
Brilliant. Thanks, Sanjay. I'm just going to have a quick look on our Mentimeter. I can see we've got a couple of questions that are coming through at the moment, but I'm struggling to work out how to change them down. Oh, right, Sanjay. Okay, here we go. So this is one for you. There's a huge risk with the funds moving into baseline without kind of contractual levers. If we've mapped nationally the need to commit to prevention and tobacco as a best use of public resources, it needs to be mandated. I mean, what's your kind of opinion on that, and what levers can we use without those contracted levers?
Yeah, so you know that I agree with all of that, don't you? I mean, I absolutely think it should be mandated. However, unfortunately, we can't, because the rules don't work that way. So therefore, I think locally we have to make the very best case possible and shine a light on it. So actually, all of us are part of the community who really care about this, and it's up to us to make sure that senior decision makers in our ICBs aren't allowed to make decisions without consequence, and that we hold them to account, and we make the case on health inequality. We make the case on the effectiveness of our services, our quit rates. I wish to. I wholeheartedly agree with you. Just to also say that when the funding was part of something called SDF funding, which was decided on an annual basis, there were also ICBs that said, well, that means that the funding is temporary, therefore we're not going to commit to it in the long term, therefore we're going to put everybody on short-term contracts. So by moving it to the hardwired funding to ICBs, that argument no longer exists.
And I think there's something there as well in terms of, I mean, obviously data is really, really important, and data around quit rates is really important, but we need, especially in our mental health services, not to sell our services short. There's a lot of work that's done around supporting smoke-free admissions, a lot of work to get around temporary abstinence and to get to people to the point where they can set a quit date. So we need to be able to make sure that we can collate all of the data to really evidence the great work that's happening. I've got another question here for you, Sanjay. If there was one tip that you could give to practitioners who are struggling to engage with clinicians around tobacco dependency, what would you say?
Oh, blimey. So specifically in the mental health setting?
Yes.
So I would do what pharma reps do and say, did you know that your mate down the road is doing this? So, they can do it. Why can't you or we? Because everybody thinks they're a special case, and that's why they don't do it or can't do it. So I would use that tactic. And, if you have information on the mental health trust down the road or in another area, use that, share it between you and use it, because I think most clinicians don't, they're quite competitive. They don't like to think that they're an outlier.
Excellent. And I think there's something there about kind of sharing learning between clinicians, getting that engagement going, and actually the work of the Royal Colleges as well to support that.
So the QUIP programme has just sort of completed, as it were. It had its final day last week. In fact, Mary was at it. And it's just terrific work, actually. And I suppose just around that last question, communities of practice where you share tips is really important. And the QUIP programme that was run by RCP site was really important, because oftentimes TDAs in an individual trust might feel quite isolated. And it's kind of the 2 or 3 of them versus the rest of the hospital. But actually, when you're in a community of practitioners, all of a sudden you feel actually you're not on your own, and you can share what you've learned and tactics.
Brilliant, thank you. And we've got one more question here. Is there going to be any further funding for specific SMI programmes for ICBs? Or is that now part of the baseline that you were talking about?
So the funding remains. So it's inpatient focused. So inpatient mental health trust. There is, you'll be aware, 7 trusts, 1 in each NHS region, that is looking at community services or models. And some of them might focus on SMI outpatient groups. I don't know what the one in Northeast and North Cumbria are focusing on. So the funding for those 7 sites across the country is still there. Whether it gets extended in the future, your guess is as good as mine at the moment.
Brilliant. Okay, thanks, Sanjay. And can I just ask everyone to show their appreciation for Sanjay joining and taking the time to join us today?
Thank you.